Good afternoon. Our topics today is challenges in vitrectomy. One of challenges in vitrectomy is large full thickness macular hole autografting. Introduction: macular hole is a full thickness defect of the neurosensory retina of the fovea, causes significant central visual impairment. Surgical advances have improved anatomical success rates. Functional outcomes remains influenced by hole size, chronicity, preoperative retinal integrity. Highlights of case presentation: first, diagnostic OCT features, decision-making process, anatomical and functional outcome. To discuss challenges in chronic large macular holes. Patient demographics: case of 15 years, female, affected eye is right eye, occupation is student. Chief complaint: progressive painless central visual loss, duration more than 1 year, difficulty with reading and fine visual tasks, no symptoms in the fellow eye. Visual acuity and examination: best corrected visual acuity, affected eye count finger at half meter, fellow eye 6/6, anterior segment normal, intraocular pressure within normal limits. Fundus examination: loss of normal foveal reflex with large macular hole, well-defined foveal defect surrounding retinal elevation. OCT finding: preoperatively clear full thickness macular hole, complete interruption of all retinal layers of the fovea, elevated and ruled edges of the neurosensory retina, prominent intraretinal cystic changes, loss of normal foveal contour, features consistent with a large chronic macular hole, with unfavorable prognostic factors, particularly hole size and chronicity. Management decision: surgical intervention advised, details counseling regarding expected anatomical success, limited functional recovery due to chronicity. Surgical goal: achieve anatomical closure, restore foveal contour, prevent further retinal damage, maximize visual potential. Firstly, when the macular hole is not large, routinely we do what is called inverted flap technique, or what is called cabbage leaf technique. In this maneuver, we peeling the ILM and put it and cover the macular hole with perifoveal sparing of the ILM. In our case, a large retinal graft, we take a graft from superior retina and bring it under heavy liquid to the large hole and covering him. The challenges here is because the challenges here is because it is large hole and not all facilities was available. So we do the graft in the superior nasal part of the retina and then migrate the flap under heavy liquid with using of bimanual techniques with forceps and covering the hole. Other challenges here, how we fixate this graft post-op. Really, I used here is silicone oil tamponading. Now, OCT post-operatively, as we see complete anatomical closure of the macular hole, restoration of foveal continuity, significant reduction of intraretinal fluid. Preoperative versus postoperative OCT, successful transition from full thickness defect to closed fovea, improvement in retinal contour and thickness profile, Anatomical success despite advanced preoperative features explains limited but meaningful functional recovery. Visual outcome post-op, base-corrected visual acuity after 2 months to 660, subjective improvement in central vision, visual stability, no post-operative complications. Follow-up, regular post-operative follow-up was done, stable anatomical outcome, no reopening of macular hole, fellow eye remains normal, and still patient on follow-up. The refractory macular hole pinnacle surgical strategies, first, autologous neurosensory retinal transplantation, as we mentioned. Second, the cabbage leaf multi-layered flap. Third, active centripetal edge mobilization combined subretinal hydrodissection to release the RPE neurosensory stiffness with a passive macular massage using a soft tip cannula. The goal is to decrease the minimum linear diameter intraoperatively, converting a refractory case into a standard type 1 closure geometry. Fourth, regenerative adjuncts, human amniotic membrane and tissue growth factor beta enrichment. In naked RPE cases, utilize a human amniotic membrane inlay as a biological scaffold. The amniotic matrix acts as a cytokine reservoir, stimulating the bridging of the external limiting membrane, which is the prerequisite for ellipsoid zone recovery. Message to home: we have mastered the anatomy. We are now chasing the physiology. The objective is no longer a closed hole, but a reconstructed fovea with restored external limiting membrane, ellipsoid zone continuity, and zero iatrogenic scotoma. Thank you, and thank you for your attention.